Nice presentation, Carlos. Congratulations. We've been doing transapical similar over the last 6.5 years with that. Can you just share with the audience how do you close the track, and why in the 15 patients that you mentioned that they have hemothorax, was it faulty implantation of the closure track, or do they bleed from somewhere else?
That's a very good question, Ziad. Well, let me tell you a little bit of the history of how we started. The first 2 patients that I did, we put coils. And I think retrospectively, we were incredibly lucky. I don't know why, but we were very lucky because nothing happened to those patients. But it was obvious that this was not the way to do it. So we started with the PDA device. And we had very good results with the PDA device. But the profile and the stiffness of the PDA device was always of a concern. So we switched to the AVP2s, which is the one that we currently use for over nearly 100 cases. The way the technique that we use, I show it in the double axis when on the aortic, I show that how we do it. Basically, we bring the device open, the distal disc open until engages into the endocardium. And the middle body of the AVP2 is inside the left ventricular muscle. And before you do anything else, you can do some injections through the sheath to make sure that you are in the pericardial space when on the sheath. But the most important thing is to see the systolic constriction onto the body of the AVP2. And after that, you open the distal part, which is probably somewhere in the pericardial, if there is any pericardial, because all those patients had previous thoracotomies. So I don't know exactly what it is. And then we release that device, and we feel the track from that place onto the skin. And some patients don't need it because they're very thin, but other patients that are much larger size, we put Surgiflow on it. Now, the cases that we did open the chest for controlling of the bleeding, in all those cases, what we saw is basically bleeding through the device. What it takes most of the times is that the surgeons just put the finger there, put one stitch to secure the device, and the bleeding gets controlled. We have not seen any coronary perforations up to this time, but I know that there has been instances where the needle has perforated one of the intercostal arteries and caused the same bleeding. The rest of the ones that we control just by draining the blood, I don't know exactly what was the cause of bleeding, but that has been the minority. Yes, please.
Carlos, thank you. Learned a lot, and we enjoyed you in our institution. You did a marvelous job with our group. But one thing that we had, after you left, everybody wanted, everybody in the hospital or in the cardiology wanted to make one of us Carlos Ruiz in dealing with those paravalvular leaks. And what I think the biggest hurdle for us is the software and the expertise that your group had developed over the years, manipulating all these images, putting them together, and understanding exactly the vertices and the angles of all the caveats of your needle entries, and putting those images together in a very functional and very user-friendly for the novice. So how do you see the progress of this technology coming together as an easy package for people starting this?
Well, thank you very much. I'm flattered for your comments, but I want to make a true, honest disclaimer. It is not me doing it. I think anybody, and I proved that with my own fellows, that they can do the access very safely. It is the advantage of imaging. That's what has made the huge difference. It's not me doing the technique, is what mechanism
se fai una ripresa adesso resta, la possiamo trasformare in foto dopo.
And imaging plays an astronomical role. The CT, if you use it properly, with what we use is the heart navigator, you need to fuse that image adequately. Now, we have developed that program with Philips over the last 7 or 8 years, And it is becoming very automatic. You can really do the volume segmentation with the push of a button.
Questo è il difetto interatriale, no?
We spent many hours in developing this approach to make it very simple. Today, the current HART navigator can very easily do volume segmentation, automatic volume segmentation, and once you have done that, you can plan it. You can sit down on the workstation and decide, well, this is what I want to enter, and see what that line is going to take you, and what tissues you have in the middle. You can bring the lungs into the workstation. You can take the lungs out. You can put the coronary arteries. So it is for you to do your homework, but the equipment will drive you there. This is for the planning. Now, the planning is not the execution. The execution, the real time.
What time is it anyway?
So we can talk offline, but I think the imaging is the answer. Thank you very much. Thank you.
Already after 6, huh?
Yes. Yes, this is the actual setting. This is the actual setting.
Okay, so we'll move over to San Donato for the last live case of the day, and I think I can see Massimo and Don. Am I correct?
Yes.
Good afternoon, everybody.
Hi.
Hello.
Can you hear us?
Yes, we can hear you. So, welcome again. Welcome back to our CAT lab. May I introduce my co-workers today. He is Luca Junior. I have as a special guest Donald Hagler working with us, great pleasure. And of course is part of the team now, Gregor Krings, that helping us doing the 3D and all the other stuff. So please, we start with the presentation of the case. Francesca.
Good afternoon, everyone. Our last case is a 27-year-old man, weighs 65 kilos. He has been diagnosed as a neonate with a double inlet right ventricle, superinferior ventricles, malposition of the great arteries, and severe pulmonary valve stenosis. At 6 days of age, he underwent a right BT shunt. And in 1992, at the Mayo Clinic, when he was 4 years old, he underwent a surgical palliation with a modified Fontan procedure. And they create a lateral right tunnel, lateral right tunnel to redirect the inferior vena cava to the atriopulmonary connection. Starting from 2013-2014, at the follow-up, there was evidence of clinical deterioration. He did an echo that showed dilated IVC, a moderate atrioventricular valve regurgitation, and a reduced systolic ventricular function. We move to...
Okay, so this is the situation. Donald, you want to comment on the surgical approach?
Yes, it was a bit unusual, and Francisco Puga described 2 incisions in the pulmonary artery and then anastomosed both of those incisions to the superior vena cava, and it seems like you'll see in the angiograms that he anastomosed in the superior vena cava and the lateral tunnel. And we had obtained an MRI on this young man a year ago and found that there was a narrowing right about in this upper portion of the lateral tunnel. And he had, and this was obtained also because he had a history of cirrhosis, which was detected by an abdominal ultrasound. So because of that, we felt that it would be important to deal with this stenosis in his lateral tunnel.
Yeah. Well, I want to show you, first of all, some angio picture, conventional angio picture. Can you show, okay, this is the first one you may see. There is a inferior and superior caval vein with a narrow part. Next one, please. This is an injection from the jugular vein. What is nice to see, just the pulmonary tree, but just below the pulmonary tree there is a part, we believe that is the second end of the caval vein, did surgery by the surgeon at the moment of the Fontan. Next one. So we did a 3D reconstruction, but before to show you the 3D reconstruction, I would like to show you the echo. Please, Antonio.
In the echo, we see here in this picture the the tunnel, the intraarterial tunnel at the middle of the image with the right pulmonary veins going to the left atrium here. So we can see with the color. We had a long axis which shows the narrowing of the tunnel in the middle here, and we tried to do some 3D reconstruction. Here we can see the tunnel from the IBC, and we see a sort of scar in the middle, the narrowing.
Okay, so any question from the audience before to follow it to show you more pictures?
Yes, Gianfranco speaking. I have a question for Antonio and for Massimo and Donald. Did you see any change in pulmonary vein flows when inflating the balloon across the conduit? Is there any risk of interference with pulmonary flow from the veins?
Yes, well actually we checked it two ways. We inflated the balloon here and looked with rotational angiography. We also inflated the balloon and looked with the TEE, and there's a picture with the TEE showing there's normal flow through the right pulmonary veins, which are right behind this narrowing, and there is no evidence of compression there either.
Okay, maybe I would like now to show you the MRI, also the 3D reconstruction. Gregor, you can show, you can comment.
Yes, of course. So please put the screen on the 3D workstation. So what we have on the 3D workstation is the MRI, which you can import as any kind of 3D imaging as a CT. So we studied the case with the MRI, and the MRI showed we had to cut some couple of things away. This is liver venous level. This is the entrance or the beginning from this intra-atrial tunnel. This is the stenosis, a little bit Diabolo-like. And this is a huge and very large connection with the RPA, LPA, and somewhere here is a cava superior. What we see here, and I'm gonna let it run a little bit more, is the upper right pulmonary vein, lower pulmonary right vein. So we see there some proximity, and this is actually what the MRI is looking like from posterior. This is the left atrium, this is left pulmonary vein, right pulmonary vein. Now from a right inferior, right lateral side. If we cut the MRI and reduce it to the most important things, we see pulmonary veins here, the stenosis from the tunnel, and everything else is just cut away. Massimo? Massimo?
Okay, we have some difficulties can you please, may we have the volume up a little bit, because there's...
We have also another question. Did you check pressures? Is there any gradient across this stenosis?
Of course we did it. What was surprising that the pressure are the same, around 12, 13, in the inferior caval vein, the superior caval vein, and in the pulmonary tree. So it was a little bit surprising. But at the same time, we were discussing, that's probably why we didn't get symptoms in this young man.
He has no edema, he doesn't take diuretics, he's on some afterload reduction because of his ventricular function, but the only significant thing is that he's had this cirrhosis, which has raised, and he still had elevated enzymes at this time. Yeah.
So, at that point we inflate the balloon into, may you show the angio, the next angio please, just to check the correct size, because we measured this narrow part. Next. Okay. You may see now probably the diameter of the balloon is a 25 millimeter bald crystal balloon, length 5 centimeters. We inflate easily up to 18 millimeters with a waist of 16, 17 millimeters.
Yes.
is Massimo. Have you checked the right pulmonary artery? Have you done an angiography in the pulmonary artery? Because it seems to be stenotic, no, very, very small flow in the right pulmonary artery.
The flow in both pulmonary arteries was similar, and actually the right pulmonary artery is well demonstrated on the MRI, and there's no stenosis. It's actually bigger than the left pulmonary artery.
So any comment or question from the audience regarding this case?
So we were going to ask the audience, would they be agreeable, or is there agreement at all in going ahead with stenting this area of narrowing because of his history of cirrhosis? Why is his blood pressure so high?
So, question for the audience: who would go for stenting in this case?
I don't know. It's maybe waking up.
Please raise your hand. Okay, who would just wait and see what's going on during follow-up? Just few, I mean, the majority are for stenting. We have a question.
They would stent it? Yes, I think the pressure measurements are not always that reliable because of the collaterals that can develop, but it still seems to be a problem with flow related to his liver function.
We have a question from the floor, please. Go ahead.
Hemodynamic, he said there is no pressure difference between the lower and upper part. But I think to answer this question, the anesthesia has to ventilate the patient vigorously and see if there is a difference or not with inspiration and expiration. And then you can get another point whether you have to go for stent or not. And you can see that even with the transesophageal echo, I mean, when inspiration and expiration, and see the flow if there is any turbulence or not.
Did you catch that, Don? So they're saying that we should do the pressure gradient without ventilation, i.e. with the ventilator turned off.
I'm sorry, I didn't quite understand the question. I can't hear quite well.
Okay, so the question was, if you did the gradient across the stenosis, but with the ventilation turned off, so with the patient, i.e. with the anaesthetist disconnecting the ventilator, is there a gradient then?
No, so opposite way. I mean, I need.
Yeah, I think it certainly could be different when he's awake.
When they measure the pressure, they have to intensively ventilate the patient, inspiration, expiration.
Oh, right. Well, that's okay.
That's why
not normally what
higher
what
pressure now, because the patient is probably a little bit.
Yeah, he has some ST things too, which I don't understand. But,
so maybe we should.
Go ahead.
We show you the size of the narrow part that is around 16. The larger part above and below is, of course, bigger, is around 30. Okay. So what your suggestion in terms of stent, bare or cover stent, in terms of diameter and length as well?
Just remind us about the nature of the material in this Fontan circuit. Is this a lateral tunnel, or is there synthetic material in there? Do we know that? Because obviously the patients come from abroad.
I can't get sorry, the volume.
Could you remind us of the nature of the material in the Fontan circuit in this patient?
Yes, we do know. It's. I have the surgical note, and it's a hemishield graft creating the lateral tunnel. And the other thing that we could see in the echo is that at this upper narrowing here, there's some buildup of fibrous tissue actually inside that area that you can see on the 3D quite nicely. So I'm not sure why this area is stenotic, but it's obviously there at the area of anastomosis. You can see on some of the 3D pictures some buildup of material in that area of the lateral tunnel.
Okay, well, can we put it out to the audience? What do people think about what stent should be used here, what the risk of rupture of this tube is? somebody like to volunteer thoughts about what to use in this conduit stenosis? Shaq, I can see you talking at the back. Come to the microphone. So this is a HemoShield graft.
I was just texting you a message, so you've interrupted it. Right, go on.
So we have a HemoShield graft, and the question is, do you feel that this should be covered, uncovered? What sort of stent should Don and Massimo use here? What do you think?
Intuitively, I would go for a covered stent, and it would be a covered CP stent, probably around either 18 and possibly 20 millimeters, but 18 looks as if it should be okay. But that's what I would do. Bare stent may well be okay, but my preference would be covered.
Okay. Anyone else? Oliver. So at the moment we've got a covered stent here, but Oliver Stump is going to give you some advice.
Okay. All right. So probably we made the right decision. We share with you the right decision. We decided to use a cover CT stent, pre-mounted cover CT stent. We decided for the diameter of 20 millimeters, and the idea was a length of 45 because we have a lot of space.
Massimo.
Yeah.
Wait a bit. There is also a comment from Oliver Stumper. Please, just patience.
No, it's. I probably would go uncovered CP because this is constriction of the HemoShield graft. I don't think there's any risk of rupture.
Okay, and the only thing I would say is if you use a covered stent and you need to refenestrate this young man later on in his life, what do you think about that, Massimo? Do you think that might be an issue, might make things more difficult?
I don't think so. No, I don't think so. It's more difficult to cross a cover stent than the bare metal stent. The problem is the fibrosis much more than the tissue that you cover the bare stent. What do you think, Don?
And there's an area in the lower part of this conduit that I think would still, although the HemoShield would be difficult to puncture in itself.
Yes, because a lot of calcification as well.
Yeah.
Okay, well, we'll let you carry on. You've obviously made your decision.
So, check the place if you want. Okay. Ok, ci date un 20? Yes, 2045. So we need a 14 French sheath, so we already put a 14 French long sheath.
Nice girth assisting you, Massimo. Huh?
Yes, that's why I love to work here in San Donato. Okay, so probably I just check is a pre-mounted stent, but I would like to check if it's really pre-mounted or just a little bit pre-mounted. Okay.
A negative prep.
Yes. Okay.
Massimo, if you've got a pre-mounted covered stent, do you think it needs a covering to protect it while it's going in through the long sheath? Or
yes.
Is it, you do, so you still cover them?
Yes, we will use the cover that comes up with the package in order to protect this stent when we are passing the valve. Okay, some negative pressure. We prepare. So inflating covered or uncovered, pre-mounted or mounted stent. You prefer to use an inflator or just a normal syringe by pushing with your hands?
We usually use an inflator.
Okay, you have it if you want, eh? As you prefer.
See this, well, we can use this one for the outer, it wouldn't be a problem.
Anyone want to make any comments about the use of an indeflator or not in this situation? I always do, but I think from a medical legal perspective at least, if you've used a pressure monitoring device, you're safer. Anyone else, any comments on that?
Okay.
Ben, I can see you nodding in the middle. Come to the microphone.
You look very stable.
Okay.
The stent. So I usually ask my younger colleague to check the stent. That way, if something goes wrong, it's his problem, not mine. If the stent moves. Well, you want to check? Look. Okay, perfect. Okay, we protected the stent now with a 14 short. Okay? Okay, ready to go. Okay, we'll go for this one. Okay.
Don, if you were doing this in the US, what would you be using?
We would apply for compassionate use to use a covered CP stent.
Or you should break the conduit before using a covered stent.
Okay. Okay. Perfect.
I would use an endograft. You know, the excluder from Gore. They're very good. You know, cover the stent. You can put it there and then just post-dilate it with a balloon. And they're very good. We've done a few cases with narrowing as well as leak. So it covers both. You know, the leak and then you can get rid of the narrowing.
Okay. And okay. Okay. I would say a little bit more, I would say. Yes, probably a little bit more, I would say. Yes. Yes. So, ready for an angio, just to check the position. Okay. Okay. Yes, ready to go? Okay. Go. So maybe let's just do one more angio. There was a lot of water inside. So please, one more, please.
Okay.
Ready to go? Go. Okay. So I think we can probably push a little bit more.
A little bit more out.
Yes.
Yeah, we'll be. Well, we have to be down by the lower vertebral space there, but I think we're probably a pretty good position.
What do you think is the right position to start, or you like it a little bit higher?
I don't think you're far off actually. And I think Gianfranco and I are both saying you should probably uncover as you've done and do another angiogram.
Okay. Ready? No, just a second. Just wait a second. Pump ready? 2 seconds. 1, 2. Okay. Okay. Please. Okay.
Yeah.
Looks good.
So I think the position is perfect. So what we are going to do now, just I will inflate the inner balloon, then angio, and then if we are happy with the position, the outer balloon, okay? Keep the position, okay?
Okay, you want to inflate the inner?
Okay, I'll do it.
Just perhaps bring that sheath a bit further back, because the balloon may kick you forward if you don't.
Gotta go to the gym.
Okay.
Oh.
Okay, angio, please.
Okay.
Just check the position again. Okay, bye. Please with the outer, record. Okay, bye. Okay, go. Stop, deflate. still deflating.
The inner?
Yes, the inner probably, the syringe is too big.
Okay.
Okay.
Want to do one more outer inflation? Or
Yes.
Okay.
Just with the outer, just inflate the outer. One more. Yes, just one more. Okay, perfect. Okay, deflate. Okay, now we can just retrieve the balloon a little bit, and then we do an angle. Up. Maybe we can go up with the. No, okay, I think it's fine. It's okay. Okay, it's coming back. Okay, it's no problem at all. Okay. Okay.
What is it? Oh, you can't.
You can look. Just have a look with the echo.
Yeah.
Probably we can get a nice picture with the echo now. Echo, please. Okay, we have the 3D reconstruction and echo at the same time. They don't need to see. And also the echo, perfect.
Massimo, here from the audience would like to see an angel.
Yes, we are taking the balloon back and then we will prepare for an angel. See, 35, 20.
Yeah, we've got 2 or 3 minutes before we need to move on.
Ok, solleva l'eco per favore. Probe up a little bit, just check. Yes, okay. Okay, ready to go?
Okay, so the obvious question, I mean, it's a nice result. You've dealt with the stenosis, but do you feel the need to potentially flare the bottom of that stent or the top of that stent?
Probably yes.
25 or something?
Yes, well, yes, maybe pallone ball 25. So I think the position is correct.
Yeah.
So we have 2 minutes. Okay. So what we might ask you to do is perhaps dilate that stent again and maybe show us the pictures.
Okay. Okay, perfect.
At a later stage, so we can move on to the next session. Is that okay?
Okay, perfect. Thank you.
That's a very nice result. Thank you very much.
Bye. Thank you, Don.
I think we could.
Okay, thank you. Ladies and gentlemen, please don't go away, stay here. I know that it has been a long day, very tiring day, but now you